Okay, hi, good afternoon, everyone. Uh, my name is Dr. Ram Singh, and today we'll be doing a talk on we'll be doing a talk today on the principles of functional cortical anatomy and delving just a little bit into intraoperative cortical intraoperative mapping. So, right. So first off, we starting off with the just an overview of functional cortical anatomy. So basically, we're just going to be looking at how we divided this into the lateral and medial aspects of the cerebrum, and delving into just the main areas of interest, which we'll get to, right? And as I said, lateral and medial surfaces. And this diagram is a good diagram because it sort of represents, in a nutshell, of what we're going to be talking about for the functional aspect, the functional anatomy aspect of it. So we're going to be looking at the frontal lobe, parietal, temporal, occipital, and the various functional divisions of these areas and the relevant functional or Brodmann areas of interest, and just a little bit into deficits. So in terms of the frontal lobe, looking firstly at the lateral aspect, mainly two sulci which divide the frontal lobe into the superior, middle, and inferior frontal gyrus. And perpendicular to all of these sulci is the precentral sulcus. Again, this area is important, as we'll see a little bit further. The precentral sulcus in terms of the motor areas. One of the important things to note here is the subdivisions of the frontal gyri and the inferior frontal gyrus. We divide it into the most most anteriorly, we have the pars orbitalis. Most posteriorly, we have the pars opercularis, and intermediate, that triangular area that is between the both of them, or intermediate, is the pars triangularis. Demarcating this region, again, are two fissures, two rami, which is an ascending rami and a horizontal rami, as we could see on the diagram, right? And again, this is just another diagram, just showing the relationship of the precentral sulcus and in the frontal lobe, and the demarcations of the various gyri, as well as the relationship of the precentral sulcus to the central sulcus of the Rolandic fissure. This is a good MR image, again, on the localization of the central sulcus. And what we note here is that oftentimes there's a fair bit amount of variability in the anatomy from patient to patient. And a way, or a nifty way in order to determine the location of this is via the what we coin the omega sign, which is basically that area here in the blue. It almost looks like the Greek letter omega, and this roughly corresponds to the area of the precentral gyri. From there, we could work backwards and work out the central sulcus and the post-central gyrus. Also, right, as we see here, right, is the presence of the omega sign right there. So in red, it corresponds to the area of the central sulcus, right? Yeah. So yeah, just a little correction. Yeah, it corresponds to the area of the central sulcus, not the precentral, right? So central sulcus. There's a prominent hook or knob on the omega sign that corresponds to the hand area knob, which corresponds to where the majority of the corticospinal tract supply the corresponding hand, the hand area. So hence we colloquially call it the hand knob area. So again, just going back into the inferior frontal the inferior frontal lobe. Again, just to touch on it again because it's quite important. We have the anterior horizontal rami and the ascending rami that splits this inferior frontal lobe into three areas again: orbitalis, triangularis, and opercularis. Um, so going on to the medial surface of the frontal lobe, it's formed by the medial surface of the superior frontal lobe, the anterior half of the paracentral lobule, and the cingulate gyrus. The cingulate gyrus and the superior frontal gyri wrap around the genu of the corpus callosum. And what we also note here is that you have the paraterminal and the para-olfactory gyri, both anterior and posteriorly, which sit below the rostrum of the corpus callosum in front of the lamina terminalis. So all of these structures contribute to the medial surface of the frontal lobe. Again, there's another cartoon that illustrates the different areas, the different sulci and gyri that contribute to that area. Now, looking at the temporal lobe, again, going back to the lateral aspect, just like the frontal lobe, we have two transverse sulci that divide the temporal lobe into superior, middle, and inferior temporal gyri. Of note here, with the asterisk, is that the Heschel's gyrus runs anterolaterally over the superior aspect of the superior temporal gyrus. We'll get into that a bit more when we talk about the auditory cortex. In terms of your medial aspect of your temporal lobe, it's a bit more complicated, but basically it's formed by the rounded surface of the hippocampus right there, and the hippocampal gyrus, and as well as this rounded eminence for the uncus. There's three corresponding strips, right? So inferiorly, we have the parahippocampal cortex. We have the dentate gyrus medially, which you can't really see here, and the fimbriae of the fornix. So the parahippocampal gyrus runs medially along the tentorium and forms the basal surface of the temporal lobe. And the uncus is medially pointing, part anterior to the parahippocampal gyrus. Again, this is it's a bit more appreciated on a coronal section here. Again, a coronal cross section of the cerebrum right here. So we could appreciate the superior temporal gyrus, the middle temporal gyrus, the inferior temporal gyrus. We have the fusiform gyrus right here, as well as the collateral sulcus. And we can actually appreciate where the optic tract runs in response to that, as well as the parahippocampal gyrus and the uncus as well. This is a really good illustration on the left. This illustration on the right is an MR coronal section, showing just a little bit more detail into the medial temporal lobe anatomy, which comes heavily into play when we're looking at functional surgery, such as in dealing with medial lobe sclerosis and seizure surgery. So again, right, you have the fusiform gyrus here, continuing on from the inferior temporal gyrus, the perirhinal cortex, continuing to the entorhinal cortex, and the subiculum. And then you have this areas here, CA1 to 4, right? And this corresponds to the hippocampus. And they're basically different areas that they have different eloquences. Some areas, more than others, are more susceptible to hypoxic injury, especially a CA4 area, CA3 area. And again, right, we have just adjacent to this, let's see, posterior cerebral arteries, as well as the basal veins of Rosenthal. So now, just moving on to a bit about the parietal lobe and the lateral and medial aspect. So again, transverse, we have the parietal lobe is divided into a superior and parietal lobule via a transverse intraparietal sulcus. So we have the superior parietal lobule right here, and the inferior parietal lobule, which is divided into two. You have a superior supramarginal gyrus, which is right there in the red, which lies just adjacent to the sylvian fissure, and an angular gyrus wrapping around almost the superior temporal gyrus right there. So those are quite important areas with regards to your in that, as we will see later, that it forms the key part of the primary somatosensory cortex. In terms of your occipital lobe, the lateral aspect, unlike the temporal, frontal, and parietal lobes, it's not as easily separated by the gyri, but the most consistent sulcus is the lateral occipital sulcus, and this is on the lateral aspect, which divides or forms the superior and inferior occipital gyri. In terms of your medial aspect, it's a little bit more demarcated in that your occipital lobe is separated from the parietal lobe via the parietal occipital sulcus. And this is this red line right there, which forms that separation between parietal and occipital lobe. We have the presence of the calcarine sulcus or fissure, which extends forward and essentially divides the occipital lobe into the cuneus and the lingula. Cuneus in purple, lingula in yellow. So we also have to talk a little bit about the marginal sulcus. It's a derivative of the cingulate sulcus, and it basically demarcates the paracentral lobule anteriorly from the precuneus posteriorly. So basically, it would separate this area from that area. So again, it arises off the cingulate sulcus, and it loops up behind the primary somatosensory cortex, like that. So it's in the red. And again, it's most easily visualized on the medial hemispheric aspect. And why is it of importance is that it's important in identification or localization of the central sulcus. So this is a sagittal T2 weighted image, and it's great for showing the anatomy of the cingulate, the marginal sulcus, in that again it runs and it almost branches off the cingulate sulcus like that, and it just loops behind the primary somatosensory cortex. So that's it in blue there, and the red represents the area of the central sulcus. In terms of localization of the marginal sulcus, there's a sign, just like we spoke about the omega sign in the localization on MR localization of the central sulcus. There's the bracket sign, which indicates the location of the marginal sulcus, also called the pars marginalis on axial MRI imaging. And we see here, that's the omega sign right there. And just posteriorly to that, immediately posteriorly, almost like a bracket on is in the orange here, that's your marginal sulcus right there. So you know the location of that, you could look out the location of the central sulcus and the precentral gyrus as a result of that. So again, putting it all together, right? We have the omega sign here. So that's your central sulcus. Because this is central, anterior to that is your precentral sulcus. Posterior to it is your postcentral sulcus, right there, with your antecedent gyri. And easily spotted, we have the superior frontal sulcus and the presence of the superior frontal gyri, the middle frontal gyri, and the inferior, which it can be visualized on this slice. So that's putting it all together. Now, talking a little bit more in terms of our respective functional areas of the different lobes. So first, going back to the frontal area, you have the primary motor cortex and the supplementary area. Now, these areas are represented by the Brodmann areas, which are cytoarchitectural functional areas that were devised in order to more compartmentalize and give function to the different parts of the respective lobes and the subdivisions. So it's represented by the primary motor cortex is represented mainly by 4, and the supplementary motor area is represented mainly by Brodmann area 6. It's the main brain region responsible for planning, controlling, and executing voluntary movements. It contains the largest population of pyramidal bed cells, which sends signals via the corticospinal, the cortical bulbar tracts to initiate muscle contraction and contralateral side of the body. The supplementary motor area, it aids in integrating sensory information to guide movement and acting as a high-level planning area, basically. So as we could note here, we have this organization. So going from more centrally to more laterally to the lateral surface, mouth, face, hand. We have that representation, or the motor homunculus, that represents that the high fidelity areas that require a lot of discrimination and dexterous movements are represented by the motor homunculus. So a large proportion of these areas are represented here. So tongue, the mouth, the pharynx, the lips, fingers, the thumb, a large portion of that is subserved by the motor area in relative to the areas such as the lower limbs, right? So, and that represents the amount of pyramidal tracts as well as the dexterity of these areas. And as we will see when we talk about the somatosensory area, there's also a sensory homunculus. So we spoke about the primary motor cortex and SMA. So though there's the prefrontal cortex, and it is crucial for high-level executive functions like decision-making and planning, personality expression, and impulse control. And it's one of the important areas that we see in traumatic brain injury, when we have a patient that may have extensive bleeds or traumatic contusions, and hence we refer to it as a frontal lobe type syndrome. It's because this area of the brain is involved in a lot of the personality and planning and disinhibition of various behaviors. So divided into dorsolateral, dorsomedial, ventrolateral, and orbital-frontal areas. In terms of the various functions, now there's a lot of overlap between the different functions, and this is not a strict, it's not strictly compartmentalized into this, but the dorsolateral area is involved with more core cognitive functions like memory and planning and organization. The orbital-frontal area is involved in more social behavior, impulsivity regulation, and inhibiting inappropriate behaviors. Medial prefrontal is involved in more self-reflection, motivational, and emotional thinking, and the ventrolateral prefrontal is involved in more voluntary response to inhibition and more goal-oriented behavior. And this is an important concept right here, Broca's versus Wernicke's areas. Broca's, corresponding more to Brodmann's areas 44 and 45, is located more in the inferior frontal gyrus, and it's located near the motor cortex, and it controls the face and mouth movements. And Wernicke's area, which corresponds mainly to Brodmann area 22, and it's adjacent to the primary auditory cortex of Heschel's gyrus, the superior temporal gyrus. And why these are important is because they're thought of as Broca's represents the area that is responsible for expression of speech and language. Wernicke's area represents the area for conduction or understanding. So based on these two areas here, we could have various types of aphasias. And this table just neatly separates, so gives an idea into the different features, so deficits that accompany the different types of aphasias. So just mainly to note here, Wernicke's, because it's the patient will present with fluent nonsensical speech, right? They would not have an intact comprehension, and they would not be able to repeat. And Broca's, again, the speech would be more pressured and non-fluent as opposed to Wernicke's. They would be able to understand, but repetition is poor. Now, you have transcortical motor and transcortical sensory. And basically, they are almost the same as Wernicke's and Broca's, respectively, with the exception that repetition is intact. So that's an easy way to remember or to appreciate the difference between a transcortical motor aphasia or dysphagia from a Broca's and Wernicke's from a transcortical sensory, respectively. There's the conduction type dysphagia or aphasia, which represents more of a lesion in between the fibers that connect the Broca's to the Wernicke's area or the arcuate fasciculus. These patients also often present with fluent speech, intact comprehension, but poor repetition. So moving on to the primary somatosensory cortex, and it's subserved mainly by Brodmann's areas 1, 2, and 3. And it is located in the post-central gyrus of the parietal lobe and the posterior paracentral lobule. Receives fibers from the thalamus in the form of the VPL and the VPM, and conveys general sensation in the form of touch, pain, temperature, proprioception, and vibration. And it receives also commissural fibers from the contralateral sensory cortex. So in terms of, we had the motor homunculus, now we have the somatosensory homunculus. And again, just like the motor homunculus, it shows that there's a disproportionately large representation of the face, the lips, hand, thumb, and index fingers, as well as the pharynx, tongue, and jaw, most ventrally, whereas the leg and the foot are located more on the medial surface, just above the cingulate gyrus. So again, a lot of two-point discrimination, a lot of nerve endings in those respective areas, such as the tongue, a lot of the tongue and the respective fingers and the hand as well, compared to the lower limbs. We have the somatosensory association or supplementary cortex, represented mainly by 5, 6, and 7, according to the literature. Receives fibers from the primary somatosensory cortex, and it also receives inputs from the different thalamic nuclei, such as the pulvinar, and it's involved in the integration and the processing of different cortical and thalamic inputs. So area 5 could be thought of as more goal-oriented movement, and area 7 is thought of as more associating visual and sensory stimuli. So in terms of our lesions, in terms of in clinical practice, bilateral lesions of the somatosensory association cortex could produce clinical entity known as optic apraxia, which is a failure to coordinate hand movements with visual input. So what this results in is that the patient would be misreaching for whether it be an object, or they would not be able to coordinate upper limb movement with what they see. Unilateral lesions in the non-dominant hemisphere could cause a contralateral sensory hemi-neglect. And very importantly, lesions in the inferior parietal lobule in the dominant hemisphere could produce what we call an adjustment syndrome, which is a tetrad which consists of dyscalculia or acalculia, finger agnosia, the left-right disorientation, and agraphia or dysgraphia, which is inability to write or difficulty writing. So we have the primary visual cortex on the calcarine gyrus, the calcarine gyrus on the medial surface of the occipital lobe is located on each side of the calcarine fissure, represented mainly by Brodmann area 17. And this receives fibers mainly from the lateral geniculate nucleus. So each fiber, each visual cortex receives input from the ipsilateral half of each part of the retina. So here we see the area that represents, this is 17, the primary visual cortex. We have the calcarine fissure, and just adjacent to this is the secondary visual cortices. And of course, the macula, with the highest concentration of the respective cones, subserved with a different blood supply in the form of the MCA. So one of the important concepts to note about your primary visual cortex is that there's a retinotopic mapping of the representation of your visual fields. So just to note here is that areas inferior, so this is your calcarine fissure here. So areas inferior to it would correspond to the contralateral superior visual field and vice versa. So areas superior to the calcarine fissure would correspond to the inferior contralateral visual field. So as you go closer to the pole of the occipital lobe, which is on this aspect, it corresponds more to the area of central vision right here. So 2-1, we could see it more at the center right here, and that's referred to as the retinotopic organization. I know we have a separate talk on neurooptal, but just note in terms of the main visual pathway lesions, complete transection of the optic nerve here, right? We get complete blindness or mononocular blindness. But as more relevant to the means of this talk, what we have is the retrochiasmic lesions, so of the optic tract. And one way to think of it is that the more posteriorly you go, closer to the primary visual cortex, oftentimes the more congruous the lesion becomes. So if we have a lesion at 7, right, which represents, if we have a lesion at 7, right, which is part of the optic tract, right, going to the left parietal lobe, we have a corresponding right autonomous inferior hemianopic defect. And this is usually incongruous, which means that there's an asymmetrical pattern if we were to do formal visual field testing. But we go more towards the occipital lobe and towards the calcarine fissure, these lesions become more symmetrical, congruous. So just that is important to note. In terms of our primary auditory cortex, subserved mainly by Brodmann areas 41 and 42, we have it's represented by the transverse temporal gyrus of Heschel, and it's often located within the Sylvian fissure. So, and it receives fibers from the medial geniculate nucleus. So almost as if we were to peel back between the frontal and temporal lobe here, located here, that's where your Heschel's gyrus is. And there's a cortical organization, columnar organization, which is based on more the isofrequency strips. So what we note here is that we recall from basic anatomy that the cochlea, we have an apex and we have a base, right? The apex is thought to be a lot less rigid as opposed to the base. Therefore, the apex subserves a lot lower frequency sounds, whereas the base serves more high frequency sounds. So that's the isofrequency strips, the organization with respect to the decibel, with respect to hearing. So note that the primary auditory cortex is connected to the different areas, such as your frontal eye field area, right, which is subserved by Brodmann's area 6, as well as 8. The auditory association cortex, just adjacent to your primary auditory cortex, the medial geniculate nucleus, as well as Broca's area. So again, the coronal section shows the anatomy pretty easily here. So just going back to what we were talking about in terms of the anatomy of the medial temporal lobe, right? So we have the superior, middle, and inferior temporal gyrus, and right here would be correspond to Heschel's gyrus, located just at the superior temporal gyrus, right there. So, and again, we mentioned the auditory association cortex, represented mainly by 22 and 24, and it's concerned more with comprehension and spoken sound. And it is connected with the prefrontal cortex via the anterior commissure and connected to various parts such as the prefrontal, premotor, parietal, and cingulate cortices via the other commissural fibers through the corpus callosum. Primary gustatory cortex, responsible for the sensation of taste, subserved by area 43. It's a cortical receptive area for taste located in the parietal operculum near the sensory areas of the tongue and the pharynx, and receives fibers from the thalamus. And one of the important things here is that epileptic foci here could result in gustatory hallucinations. And lesions at this area result in impairment of taste contralateral to the location of the lesion. In terms of our olfactory cortex, subserved mainly by area 28, and it consists of the piriform and the periamygdaloid cortex at the temporal lobe tip. And it receives fibers from the lateral olfactory striae, primarily. So this has the distinction as being the only functional cortex which receives fibers without it necessarily synapsing into the thalamus. And it is implicitly related to the surrounding limbic system. The entorhinal cortex is the olfactory association area, and the clinical relevance is that epileptic foci here in the form of an infarct or infection, demyelination, tumors could cause olfactory hallucinations. These are just two pictures from the CETAW that basically gives an overview of the main different functional Brodmann areas there, which could be read at your leisure, but it basically summarizes all the different Brodmann areas. Now, we now complete the functional cortical anatomy, and we just delve in more into the basic principles of the intraoperative cortical mapping. So, using the knowledge of our functional cortical anatomy, our goal is to maximize extent of resection, and in the context of intraoperative mapping, we're going to talk more in the context of neuro-oncology, which is one of the major applications of cortical mapping. So we want to maximize the extent of resection while preserving or even improving the quality of life and to optimize oncofunctional balance. So in terms of low-grade glioma surgery, and this is quite important, as well as to some degree in high-grade glioma surgery as well. Modern mapping techniques have supported the dogma of early and supramarginal surgical resection, as opposed to a watch and wait type of management, where we wait until the patient has functional deficits or becomes more symptomatic. So it must be noted that there is a tremendous inter-individual variation in anatomic function and due to the process of functional reorganization. So this may explain why we may have a patient with, for example, a large low-grade glioma, may be affecting the motor strip, and they may not necessarily have deficits in the form of a contralateral hemiparesis or hemiplegia, is because of functional reorganization, especially more for slow-growing benign type lesions. So in order to preserve neural function while achieving a more radical removal, there's the the emerging philosophy that suggests that individual functional mapping guided resection is now advocated as opposed to purely image-based guided surgery, as was classically proposed. So this optimization of benefit to risk ratio aims at improving quality of life as well as prolonging overall survival. And it is only by studying the distribution of the parallel and delocalized large scale cortical or subcortical neural circuits in the individual level is that we're able to map real time these lesions. So in essence, what we're saying here is that surgical resection is pursued until eloquent structures have been reached, with no margin left around the networks critical for brain function. So it is important to note the dynamics of neural subcircuits mediating specific subfunctions, their interactions, as well as the potentials and limitations for functional compensation. So to optimize oncofunctional balance. So one of the things is that we need to know is that the limitation of functional neuroimaging for preoperative mapping. So when we talk about functional imaging, we talk mainly about functional MRI, or fMRI, and diffuser tensor imaging. These have been predominantly used in the past, but again, as more modern techniques have come about in the form of mapping, they have seen to have their limitations. For example, functional MRI is not suitable at an individual level in surgical practice because it does not directly reflect the reality of brain processing, but only gives a very indirect approximation of cerebral functions. And that is based upon biomathematical reconstructions. So comparison between fMRI and intraoperative electrostimulation mapping, or IESM, found only 71% of positive correlation for motor function, which means that there was a degree of margin for error with fMRI as opposed to electrostimulatory mapping. There have also been poor correlations for language, so approximately 33% difference. And the overall sensitivity and specificity for fMRI is about 37 and 83.4% respectively. Functional MRI is unable to differentiate areas that are essential for brain function and that should be preserved during surgery from areas involved in but not critical to a given functions. So what this is that areas that can be surgically removed because functional compensation can occur, and fMRI cannot give us this information. Diffuser tensor imaging is a useful adjunct, but when dealing with abnormal or often distorted fiber tract anatomy by tumors or gliomas, there's a risk of error because of the diffusion properties affected by the tumor. So again, this explains there's only a 82% concordance rate between DTI and electrostimulatory mapping. DTI is unable to provide any information about the functionality of a specific tract fiber. And again, just like fMRI, it only gives indirect data concerning the structure. So it's not very reliable for planning. Now, due to the major anatomical variability across patients and within the same patient over time, due to cerebral reorganization, intraoperative functional mapping must be systemically achieved under local anesthesia in many of these patients, such as low-grade glioma patients. So even though motor mapping could be done under general anesthesia by means of intrasurgical electrophysiologic monitoring using motor evoked potentials, it's unable to map cognition with the same accuracy as an awake patient. So especially for complex movements of the hand, for example, or bimanual coordination, such as playing a musical instrument or performing fine dexterous activities such as writing or painting. IESM is the sole technique that enables the direct identification and subsequent preservation of the different cortical, subcortical neural networks critical for function. So in terms of your principles, we have the somatosensory evoked potential phase reversal technique. So what this means is that this is a means of indirectly identifying our central sulcus, which would then allow us to use the different cortical techniques, as we would see a little bit later. So somatosensory evoked potentials can be recorded from the exposed cerebral cortex by using this phase reversal technique. So basically what we do is that we stimulate the median nerve at the wrist, or we could stimulate the posterior tibial nerve at the ankle with the corresponding parameters right there. And we take recordings performed from the scalp, CZ and FZ at the legs, and C3 or 4 or CZ at CZ at the arms. And this is in accordance with our 1020 international system for EEG. After the craniotomy section, a strip electrode is placed across the exposed motor cortex and the primary somatosensory cortex traversing the central sulcus. So what we look for is a mirror image waveform that can be identified if some of the contacts of the strip electrode are placed on the opposite side of the central sulcus over the motor cortex. For the phase reversal, a strip of electrode with 48 contacts with a distance between 1 centimeter between them is used. And it has a relatively high success rate between 91 to 97% in localizing the central sulcus. So basically what we're looking at here is that we're going to either stimulate the median nerve or the posterior tibial nerve. Our readings now from the subsequent scalp recordings here are going to show different downward deflections. What we're looking for in terms of phase reversal is the area or the dot area in which we have the transition from a downward deflection to an upward deflection. So hence that's phase reversal. And that would allow us now to then place the corresponding grid or electrodes over the subsequent area. And that area of transition now would correspond to the area of the central sulcus. So that's a quite reliable way of localization of your central sulcus. Now, in terms of our functional mapping strategies, two theories underlie the choice of the strategy. So one is that there's a concept that thresholds could vary across the exposed cortex depending on the task being assessed and the location, in keeping with the observation that the after discharge threshold could vary significantly. So hence an attempt to maximize stimulation currents at each cortical site to ensure the absence of eloquent function. Or two, the second theory is that you want to keep the stimulation intensity constant while mapping the entire cortex and set the threshold just below the lowest current observed to induce after discharge thresholds. So this strategy is aimed at minimizing the risk of inducing after discharge potentials and clinical seizures, but it could miss the identification of eloquent cortical sites. So one of the two techniques that we describe here in terms of our mapping is the Penfield technique or the 60 Hz Penfield technique. And it's a form of direct cortical stimulation. In terms of the practical points, so we mentioned the phase reversal technique right there. So once localized with the phase reversal technique, direct cortical stimulation is required to confirm the localization of our motor cortex. So what we're going to do is we're going to place a bipolar electrode with the tips 5 millimeters apart and deliver biphasic current at a frequency of 60 Hertz at 1 millisecond durations. So the current is adapted to each patient and it is determined by progressively increasing the amplitude in 1 milliamp increments from a baseline of 1 milliamp until a functional response is elicited with 5 milliamps as the upper limit under local anesthesia. So with the goal of avoiding seizures. The patient is never informed when the brain is being stimulated, and each cortical site, represented by a 5 by 5 millimeter part of the entire cortex, is exposed by the bone flap and is tested 3 times to determine whether it is functionally crucial by generating disturbances during the 3 stimulations and with normalizations as soon as we stop the stimulation. In terms of the muscle responses could either be observed visually or documented by multi-channel electromyography. If no response is elicited with an intensity as high as 16 milliamps, which we usually don't go that high, that area of the cortex could be considered essentially non-functional and thereby safe to remove. So a limitation to the reliability of cortical mapping is the large variability of threshold for positive mapping response across individuals and within the same individual. A motor response from the same muscular group can be elicited from more than one cortical site using different stimulation intensities. So due to the use of a relatively low intensity electrostimulation, most literature would state a mean of 2.25 to 2.75 milliamps on average. Electrocorticography, which is essentially an EEG on the cortex of the brain, is not necessary in order to obtain positive mapping, and hence it limits the risk of intraoperative seizures and epilepsy. Again, ECOG or electrocorticography is essentially an EEG, or in which they have subdural grids are being placed on the cortical surface in order to determine epileptic foci. And it is quite invasive, and it carries a respective inherent risks from the invasive nature of placement. But it carries advantages over your conventional scalp EEG in that it offers higher spatial resolution, broader bandwidth, and higher amplitude signals that would otherwise not be generated if you're recording from the scalp. Now, at least one picture presentation without stimulation must separate each stimulation, and no site is stimulated twice in order to avoid seizures. And why is that important? Why we're working so hard to avoid seizures is because seizures could actually influence the reliability and the accuracy of our mapping. Oftentimes, in the event of an intraoperative seizure, if it's provoked, we inform the anesthetic team. Supportive measures are put in place, such as management of BP, temperature, pulse, ventilator settings, glucose. We want to be able to irrigate the site with that's supposed to be cold saline or Ringer's lactate, and appropriate loading of anti-epileptic medication if the patient has not already been loaded. Seizures can cause transient changes in the cortical excitability. So it means that you need a higher stimulation intensity in order to elicit the same response shortly after a seizure, which could ultimately influence and decrease the accuracy of our mapping. So disadvantages of the pen field technique. Well, you do run the risk of epilepsy in as many as 20 patients, despite therapeutic levels of anticonvulsants, and regardless if there's a history of preoperative epilepsy. Children less than 5 years of age, direct stimulation of the motor cortex for mapping, it may not necessarily need localizing information because of the relative unexcitability of the motor cortex. And again, this is a mapping technique, and it's not a monitoring technique. So no matter how often the cortical and subcortical stimulation is repeated, we cannot assess the functional integrity of our motor pathways continuously during the surgery. We go to the second of the two main techniques, which is our short train of stimuli technique. So more recent is the more recent of the two mapping techniques compared to the pen field technique. And it's been integrated into monitoring techniques to continuously assess the functional integrity of our motor pathways, such as the cortical spinal tract, and hence increase the inherent safety. So muscle motor evoke potentials are initially elicited by a multipulse transcranial electrical stimulation, or TES. We have the application of short trains of 5 to 7 square wave stimuli in 500 microsecond duration, with an interstimulus interval of 4 milliseconds. And these are applied at high repetition rates, as high as 2 hertz through electrodes placed at C1 and C2 at the scalp sites, right? C1 and C2 corresponds to central areas. The maximum stimulation intensity should be as high as 200 milliamps. And we're going to record our muscle responses via needle electrodes inserted into the contralateral upper and lower extremities. So after the craniotomy and exposure of the cortex, and once phase reversal has been performed, we're going to directly stimulate the cortex of the motor area using monopolar stimulating probe, as opposed to the bipolar probe of the Penfield technique, in order to identify the cortical representation of the contralateral facial and limb muscles. So sometimes the short train of stimuli technique requires slightly higher current intensities as opposed to the Penfield technique. However, unlike the Penfield technique, which uses 60 hertz, we use it in a very short train. So to charge the brain. So the charge applied to the brain is significantly reduced. So we run less risk of inducing intraoperative seizures. So the short train of stimuli technique does not induce strong muscle twitches that may interfere with the surgical procedure. The large number of muscle fibers that are stimulated, the lower the chance of a false negative mapping result. Again, just a diagram illustrating the application of the monopolar probe on our train of stimuli, 5 to 7 hertz with a 4-7 millisecond interval between them. It's crucial to benefit from positive cortical mapping before beginning to remove the tumor, with the goal of tailoring the section according to the distribution of neural networks. It is also recommended to perform a wider bone flap with the goal of obtaining systemic functional responses prior to excision, and exposing at least the ventral premotor cortex, which will generate articulatory responses in all cases during stimulation. Positive mapping may also enable optimization for the extent of resection, since the resection can be pursued until eloquent areas are encountered. So basically what we are going to do here is increase the rate of supratotal resections. And by doing that, we want to increase our extent of resection and hopefully the overall survival. In terms of our warning criteria and correlation with the postoperative outcome, now, there are certain changes in the motor evoked potentials that are used to inform the surgeon about impending injury to the motor system. The thing to take away here is that there's no definite parameters indicative of significant impairment in supratentorial surgery as compared to spinal cord surgery, where we use our motor evoked potentials and SSEPs. So, but as a general rule of thumb, a shift in latency, decrease in the latency of 10 to 15% and a decrease in amplitude of 50 to 80% correlate with some degree of postoperative motor defect deficit. So a persistent increase in threshold to elicit motor evoked potentials, or persistent drop in muscle motor evoked potential amplitude despite preservation of BP, adequate anesthesia, and normothermia represents a warning sign. And this correlates the correlation between intraoperative changes in the muscle MEPs, such as the amplitude and latency, and the motor outcome are very not linear and most times are not concordant. So we spoke about the principles of cortical mapping, and we just move on to just briefly touch on subcortical mapping or stimulation. So as with the introduction of more modern techniques, it often argues against the concept of a rigid or fixed cortical functional organization. Basically, or essentially, what this means is that you have different areas of overlap and different areas that may subserve the same function. So subcortical mapping has emerged over the years as a tool in order to preserve our white matter functional boundaries and aid in the decision as to when to stop tumor resection. An injury to white matter tracts could induce irreversible neurological deficits. The cortical spinal tract could be localized at the subcortical level using the same techniques for direct cortical stimulation as described before, although cathodal rather than anodal stimulation is used. In subcortical stimulation, we have a threshold current of 1 milliamp, roughly corresponds to 1 millimeter distance between the stimulation site, the cortical spinal tract. We use a cutoff of 3 milliamps, and this has been consistently reported, suggesting that the risk increases when the cortical spinal tract is at least 3 to 4 millimeters away from the dissection. We have the modern adjuncts such as the ultrasonic aspirators combined with a stimulating probe available, and they increase the temporal spatial resolution of subcortical mapping using as low as 1 to 2 milliamps as tolerated. Subcortical mapping cannot detect vascular injuries, but it is essential in order to determine the distance from the cortical spinal tract in order to avoid injury to this important pathway. In terms of our additional considerations, we look at two main things, meaning mapping of the cortical spinal tract at the level of the cerebral peduncle and mapping of the different motor nuclei on the floor of the fourth ventricle. So mapping of the cortical spinal tract at the level of the cerebral peduncle. Oftentimes, at the level of the brainstem, at the midbrain, we want to map the location of the cortical spinal tract at the superior cerebral peduncle. What we use is a handheld monopolar stimulating probe as a cathode and a needle inserted into a nearby muscle as the anode. If a response is reported from epidural electrode, a single stimulus is used. If the response is reported as a compound muscle action potential from one or more muscles, a short train of stimuli is used. Stimulation intensity is often at 2 milliamps, and when a motor response is reported, the probe is moved in increments of 1 millimeter in order to find the lowest threshold to elicit that response. So this is important when we're looking for a safety corridor for with brainstem with midbrain tumors, especially midbrain gliomas. Roton described the lateral mesencephalic vein being a useful landmark for midbrain tumors that displace the cortical spinal tract. So we have the lateral mesencephalic vein that runs here from the sagittal view, and here looking at it posteriorly, we have the lateral mesencephalic vein. And it's the cortical spinal tract is usually located anterior to this vein. So it gives us a gross anatomical estimation of the cortical spinal tract. Neurophysiologic monitoring allows the identification of the tract and hence a safe entry zone to the lateral brainstem in these cases. Again, looking at mapping of the motor nuclei of the cranial nerves on the floor of the fourth ventricle. We also utilize a handheld monopolar probe. We record compound muscle action potentials in muscles innervated by the different cranial motor nerves. And we use the single stimulus at a 2 millisecond duration at 2 hertz frequency. No more than 2 milliamps current should be used. In order to record the responses from the cranial nerves, so we're looking mainly at 7, 9, 10, and 12. We put the wire electrodes into the different muscles innervated by these cranial nerves. So for 7, we're looking at the orbicularis, oculi, and oris muscles, as well as the posterior wall of the pharynx and lateral aspect of the tongue muscles. And that would be for 9, 10, and 12 respectively. It is important to note that this is not a perfect technique, and the post-operative functional outcome is not always predicted by post-resection responses. So this is seen more with the motor nuclei of the seventh nerve, in which the brainstem mapping cannot detect injury to supranuclear tracts originating in the motor cortex. So we can't detect a supranuclear 7 paralysis, even though our lower motor fibers tract integrity is preserved. So this is an example diagram of the setup of the mapping of the different motor nuclei of the cranial nerves at the base of at the floor of the fourth ventricle, and where we place them. So look at the orbicularis, oculi, and oris right there for 7, upper and lower. We're looking at the posterior wall of the pharynx for 9 and 10, and the lateral aspect of the tongue for 12 right there. And again, the area with our monopolar stimulating probe corresponding to the motor nuclei. So similar to 7, cranial nerve 9 mapping is of limited benefit as it records activities on the muscles of the posterior pharyngeal wall after stimulation of this nuclei. And what it really assesses is the functional integrity of the efferent arc of the swallowing reflex. But it doesn't really give information on the afferent pathways or the afferent-efferent connections within the brainstem. So inherently, an intrinsic limitation of all mapping techniques is that they do not allow for continuous evaluation of the functional integrity of the neural pathway, and this applies to most of the mapping techniques. So it must be noted that, especially in slow-growing lesions, brain reshaping allows for functional compensation due to recruitment or different remote areas within the ipsilateral hemisphere, or the recruitment of our contral hemispheric homologous areas. It is important to note that prior to mapping, we need a thorough neuropsychologic evaluation, and deficits are related to the migration of glioma cells along the white matter tracts. And oftentimes that normal or routine neurologic examination is not nearly sensitive or specific enough in order to determine these neurocognitive or neuropsychologic deficits. So we need a thorough neurocognitive evaluation, and we must take into account the patient's quality of life, as well as the patient's defined as the level of activity prior to surgery, and how it would impact things like job and hobbies, lifestyle, and projects after surgery. So what this basically means is that we need a multidisciplinary approach involving the surgeons, the neuropsychologists, neurologists, in the interpretation of the complex neurocognitive and neuropsychological perioperative assessment. Again, that brings me to the end of the presentation. These are my references.